Hello, thank you. I'm very aware that I stand between you and your evening's entertainment, so I shall try and make this relevant, hopefully interesting and maybe energizing as well. I'm Zella King. I'm from the University College London, and this is joint work with Craig Wood, who is a senior nurse and a senior operations manager at University College Hospital. And I'm going to be talking about a real-time tool that's running 5 times a day, sending predictions to the hospital about emergency bed demand. So this is very different from what Tom was just talking about. This is like, how many beds do we need in the next 8 hours? And I'm going to sort of try and make it a little bit relevant by starting with the comment that if you have the misfortune to turn up in a A&E department in the UK, there are 2 things that you don't want to hear. The first one is, I'm really sorry, but we are going to need to admit you to the hospital. And the second one is, I'm really sorry, but there are no beds at the moment, so you're going to have to wait in the emergency department until one is available. Craig is the person at the other end of that problem. So his team work in a coordination centre. They're responsible for patient flow through the hospital, so partly it's about finding beds for people coming in through the front door. It's also about trying to expedite the departure of people at the other end, and A&Es are really blocked often by downstream problems. So I'm going to talk a bit about Craig's world and then the model that we have built to try and assist him and his colleagues in this process of predicting emergency demand. And then at the end, I'll show some of the aspects of the model that we built, and I'll also talk about some lessons, what we've learned about working as a joint hospital academic group. So this is the sort of view that you get as a bed manager. So you've got the general public sort of presenting themselves at A&E in the front door. I've simplified it here into 3 pathways. So if you're acutely injured or unwell, you're likely to go to a majors pathway. If you are mildly, sort of minor injury or something that's sort of GP level issue, then you'll go to a minors pathway. And then ESDEC is for same-day emergency care, which is a relatively recent introduction into UK A&Es, or at least England A&Es, I'm sorry, I don't know about the other countries, where the idea is for admission avoidance, so clue in the name, same-day emergency care, but actually, because they're staffed with higher levels of resources, same-day emergency care places often end up boarding the patients who are waiting for beds. So you get a lot of people sort of basically staying overnight in ESDEC waiting for a bed to be free in the morning, as things stand in UK hospitals. So Craig's view would be that he can see the people who are waiting for a bed to be assigned. He can see the people who have a bed but are waiting for it to be made free because it could be still occupied, or it could be waiting to be cleaned or waiting for portering. And then you can obviously see the view of the hospital as it is by specialty and see where the available beds are. And this is not an unrealistic picture where you've got many fewer available beds than you've got people waiting for them. So the job they do in order to kind of try and manage capacity through the hospital, this is the way they currently communicate bed capacity position. So this spreadsheet itemizes ward by ward the current bed capacity, how many departures from those beds they anticipate, and then the expected position at midnight tonight. I've put a red rectangle around to illustrate the heuristic they currently use to work out how many emergency beds they're going to need. So yesterday, or on a comparable day, they admitted 50 patients. So that's the 50 in the bottom row, and it's obviously sort of itemized above. So far today, they've admitted 15. So therefore, the logic is that between now and the end of today, we're going to need to admit 35 more patients. So that's, like Tom was just saying, a point estimate. Doesn't give you any sense of the uncertainty around that projection. This spreadsheet goes around the hospital. Everyone from the chief executive, medical directors, senior nurses, support services, it goes externally to the ICB. And it's used as an instrument for escalation. So if you get too many red areas in that view that I just showed you, then people have to do things. That would typically be, getting wards to kind of start speeding up the process of trying to discharge patients. One of the problems of that is that you don't know necessarily, where to target that action. So the tool that I'm going to talk about is one that's trying to promote targeted action of this problem. So as you can see, the times of day that it goes out around the hospital, and there are 3 huddles as well that take place where they check in with every ward about potential discharges, and it's always hassle all the time to try and get people to leave or to try and speed up the departure of patients out of beds. But the challenge for this, as from a point of view of sort of predictive analytics, is to find ways to represent the hospital state as it is now, but also short-term future demand at a time when decisions are being made, like in those huddles, in a way that can motivate action. So the first piece of work we did on this, and this is with a wider group, you'll see some of the names here and also the funding sources. So the first piece of work tried to address this problem for the hospital, and we also published it in Nature Digital Medicine. And in that you'll find some of the sort of more academic evaluation that Richard was talking about earlier in terms of sort of presenting this in terms of its sort of scientific rigor, I guess. What we did in that paper was really 3 things that were useful. One was we predicted admission using the hospital's electronic health record and predicting each patient's probability of admission real time. So I've kind of coloured them here in sort of various shades of green, depending on how they're, it's a toy example, but their probability of admission. So the contribution here was partly about thinking when you're training a model for real-time prediction, that's interesting from how you structure the data, because you need incomplete visits to make predictions on. So there's some different ways you can go about that, and if anyone is interested in doing real-time prediction, do talk to me, because I've done lots of thinking about how to make data which is historical, so all the visits are finished, into data which is part complete in order to train on it. Same thing we did was aggregate predictions over a distribution of patients. So if you're Craig, whilst it may be important to know whether a given patient has a high probability of admission, it's more useful for you to know how many beds you're going to need. So that's where aggregating the findings comes in. And we were able to work with the idea of uncertainty. These are not sophisticated people with maths. They're generally senior nurses, so they don't necessarily have a strong understanding of probability, but we've been working with them to express the idea of uncertainty and to say, well, we think from the patients who are in A&E now, there's a 90% probability that you're going to need at least 20 beds in this example, and there's a 70% probability that you may need 25 beds. So it's that kind of level of communicating uncertainty. But the other thing we wanted to add to it was also, if you're making predictions, say, at 3:30 this afternoon for over the next 8 hours, you want to think about people who haven't showed up yet, because A&E departments do have targets, and ideally we process most people, either we admit them or we discharge them within 4 hours. It used to be a 95% target. I think it's been watered down. But in theory, if you show up at A&E now, you would expect to be admitted by 8 hours' time. So therefore, even if you're not there yet, and you're not in the electronic health record, so we can't do nice machine learning predictions on you, because we don't know about you yet, we still want to factor your demand profile into our predictions. So that's the third thing that we added in this first paper. However, this was useful in the ways that I've outlined, and it was a real-time application running every day, sending predictions at the times of day that were useful for those huddles that I mentioned. But an operationally useful tool has some other attributes, and these are my 3 A's. I'll come back to them at the end. So ideally, the predictions that you generate are aligned with how the hospital operates, particularly, this user group, these bed planners, the predictions need to tally with data they can already see and coincide with the operational rhythms that I mentioned in terms of these five daily spreadsheets and so on. Ideally, it would be actionable in the sense that you can target action. I've already alluded to the fact that if you only can communicate the bed capacity position at the level of the whole hospital, then you don't know where to target action. Maybe surgical beds are going to be really under pressure tonight. If you knew that, then you could push activity towards discharges in the surgery wards, and then you've got someone you can go and pester because you've got a head of the surgical division. And I think someone alluded to this, I think it was Tom just now, that Ideally, predictions are informed not by poor historical performance, but by aspirational targets, and I'll say more about that. So in the ideal bed manager view, we would be able to supplement what he can see with some other things that would allow him to predict by specialty, and also incorporate the people who have yet to arrive. So in my kind of extra table at the bottom there, which I've added to the previous diagram, I've added the view that Craig can see with his lists of patients needing the ones he already knows about, but then in addition, amongst the patients in A&E who aren't yet in receipt of bed requests or decisions to admit, by specialty, so broken down into the medical, surgical, and in this particular hospital, hematology and oncology and pediatric, give a picture with some probability around it of how many beds they're going to need, both for those in A&E and then also those yet to arrive. And so this is what we wanted to aim for. And as I've already alluded to, if we want to predict in the next 8 hours, we'd ideally like the predictions to reflect the fact that the A&E is performing to hit targets rather than performing based on poor patterns of performance that we've learned from the past. So we needed to extend the previous work, the published work, in these ways in order to be aligned, to be actionable so that we could help them differentiate between the patients they already knew about and the ones that who were being treated but didn't yet have bed requests, and in an aspirational way. So this is what we now send. And yes, it is a spreadsheet, and yes, we do send it by email. But we're coming, and I'll come back to that, but we're both quantifying patients they already know, the ones they have with decision to admit, that's columns B and C, and then, I hope it's readable somewhat, and then we're also giving a sense of how many beds to plan for over the 4 different areas of the hospital with a 70% probability and a 90% probability, including separating out patients in the A&E now and those yet to arrive. So I'm just going to run through a very a simple example from last week, just to give you a sense of what's going on here, how we're actually generating this stuff. And so there are 7 steps, and I'm going to just go through each of them with an example. So the first step is to start with patients in the ED at a given point in time. So I made this presentation last Wednesday. This was at 3:43 in the afternoon. And here I've got the detailed A&E locations down the left. I'm not going to go into the details of them, but you can see patients according to how long they've been in the hospital on the horizontal axis. And they're coloured according to whether they're being assessed and treated, whether they're already known to the bed planners and waiting for a bed to be assigned, or whether they're waiting for a bed to be free. So already you can see a bunch of purple dots that wouldn't be visible on the typical bed planner view. If we now take out the ones they know about, because they've already got bed requests, then you get left with a smaller number. And then we can use our machine learning model to assign a probability of admission to them. I'm not going to talk about the detail of the machine learning, but I have slides at the end that I can happily show afterwards if anyone is interested in the details of the machine learning. But this is using nearly 200,000 A&E visits over a period of a year and a half. And what's interesting about this view is you can see here are some patients which aren't yet known to the bed planners, but they've got large dark circles. So those are the ones with high probability of admission. You can see there's one in resus and there's one in majors, and there are several others who could be worth thinking about if you're a bed manager. And I've just really to make the point that these are the patients they don't know about, so the ones that could factor into their thinking. Then we think about, well, which specialty do we think these people are most likely to be admitted to? And here I'm just doing it with the medical specialty. So I've coloured them according to the model's predictions on whether these will be medical patients. So they'll equally have a prediction for whether they're going to be surgical or for the other areas. So here you've got a few patients who have had a consult with a medical inpatient specialist. So when that happens, the model gives them a high probability of being a medical patient, and the others it's less sure about. So now we've got 2 probabilities, the one of probability of being admitted and the one of being admitted to a given specialty. So you can multiply those to get a sense of each patient's probability, if they're admitted, of being admitted to a medical specialty. So now we've got one patient in majors, hasn't been there very long, but very high likelihood of admission. And then you've got some others, and this is where this becomes interesting, because you've got quite a few people here who don't have a high probability in and of themselves, but the way patterns work is that even some of those with a low probability may end up being admitted. So what we want is a probability distribution over the number of beds that we need from these patients. And in order to kind of communicate what's behind this, if you imagine for a moment a simplified example where you've got 10 patients and they've each got a 10% probability of admission, that would be like rolling a 10-sided die 10 times. So your expected value would be that you would admit one patient, but actually you could also reasonably expect to get no patients, but there's some probability of getting 3 or 4 patients. So this is what we're doing with each patient. We've got their individual probability of admission, which is personalized. It varies patient by patient. But we are taking those individual probabilities and aggregating them in this way to get a probability distribution over the number of beds needed for patients in the A&E at that moment in time when those predictions were made. So the bars show the probability of each number of beds, and this is where we convert it from an individual sort of level exercise into something which is useful operationally. I've coloured them according to the 90% probability that I mentioned before. So 90% of the probability of mass, if you like, lies on the blue bars. So that's why we said we think you're going to need at least 5 beds for these patients in the next 8 hours. Then we want to do the same for the patients who are yet to arrive. I've already mentioned the fact that performance against A&E targets has been dwindling, and this is data that was available from NHS England up to the pandemic. But I'm not quite sure what's happened to this data now. Anyway, there is a clear downward trend in terms of the speed of processing of patients through A&E. And so if we were to use historical performance to predict how many patients they would process in the next 8 hours of those yet to arrive, we might end up with very, very few, which wouldn't be realistic. So what we want, as I've already alluded to, is the idea of patients being seen within the 4-hour targets. So that's what we want to do. So we use that idea with a Poisson distribution of patterns of arrival in order to generate another probability distribution over the patients yet to arrive. Combine those together, and that's what you end up with this kind of idea. So what I really want to, so these are Craig's words on this slide actually, and this is his sort of view of how he's changed his spreadsheets in order to incorporate our predictions. So that spreadsheet has a cover sheet. This is the cover sheet. They now bring in figures from the predictions generated by our app, and give a sense of predicted capacity over the next 7 hours. Now this is very, very far from the holy grail of health informatics, right? This is a spreadsheet being sent around to decision makers in a hospital. But this is how people's lives work. And we had a big debate in the project team about whether we wanted to support them sending emails around and generate something that would be useful to them, or whether we wanted a shiny dashboard that they would have to go out of their way to look at. And so pragmatism won with this. We send something they can copy and paste and drop into this spreadsheet. And it's kind of almost embarrassing to admit it, but it is a major, I don't know, I feel like a major sense of victory that this has actually been implemented into their workflow. And I think if there was a shiny dashboard, I'm not sure that I would be able to say that. So here are some reflections on working as a joint hospital academic team. And this was Craig's comments firstly, and then I'll give mine afterwards. So from his point of view, I asked him, what we've been working together for 3 years. What are his kind of reflections? And I think he's very keen to emphasize that academics work on different funding cycles. Our timescales are different. We have really different expectations about how long we think it should take to train a model and validate it. He found it helpful that we understood the need for an end product. It wasn't just an academic exercise. And I would say, in sort of to support that, it also helped that he was a perhaps an unusual senior nurse flow coordinator in the sense that he was very interested in data and in AI. On deployment in the hospital, and these are the key things, is it useful? So is it giving them any information they don't already have? Is it maintainable on our system? And that is actually a really big if. So the application was built based on grant money from outside the hospital. It's only maintainable on their system if there's someone to keep the lights on. And currently, that's fragile. So it relies on me and a couple other people still being around, still making sure it works. So we are far from over that very last mile of getting this into, I don't know, a secure hospital informatics environment. Nonetheless, they were confident enough in it to retrain the people in their team and say, okay, we're going to include these predictions in our spreadsheet. And the other factors about this particular hospital is that there was a big investment in an EHR with Epic, so there were many more opportunities for data to hand, and I think during the course of this project, the hospital was understanding how rich its data is and starting to think more carefully about information governance. But they had, and it was interesting, Ben said this morning that it's all about repetition, and I've heard some senior clinicians in the hospital going on and on and on about health analytics, endlessly about the need for it, and it's that kind of persistence which has led to the hospital investing in analytics at all. So there's a platform called EMAP which made this real-time sort of machine learning approach possible. It wouldn't have come out of the box with Epic. My reflections are, the first project we did positioned us as credible. So although it didn't go all the way over the last mile, it went far enough to make people think we had something interesting. Relationships took a long time. So observing and participating in work processes. As any analyst, I think, the more you can actually be sort of close up with the people who are benefiting from the reports and the dashboards that you're creating, the better. I've already mentioned the fact that we hear so much about this shiny world of AI that's going to make medicine better for us all, but yet trying to work within. These people have deluges of information coming at them all the time, and it's trying to find ways for incredibly busy and stressed people to pay attention to something new is really tough. So to make it easy for them. In terms of making it actionable, one of the reasons why we couldn't do all the things we wanted to do in the first phase of the project was because the data wasn't available to us in real time to do it. So that was about just understanding how hospitals change things and then carrying on asking the same questions. Can we have this data on bed requests so that I can differentiate between the patients in the emergency department who Craig already knows about and the ones that he doesn't know about? Because until I have that data point, I can't do that. And then I think in terms of making the product aspirational, when we first built this and we based it on historical data, you could see that the predictions weren't very realistic in terms of sort of how quickly people be processed through. So nonetheless, being able to show something and then talk about, well, if we change this so this could be aspirational based on your current and forward-looking targets, wouldn't that be better? But again, there's a communication exercise there to do about the predictions that we're sending out. But if you want to quantify true demand, then really it has to be based on what we would all hope as patients in terms of targets for treating us. The other thing I would just mention is that we were quite lucky. I think that the project it was not a highly funded project at the outset, but there were fluid deadlines, and there was more funding both for my role and for a bit more for Craig's role. So we benefited from a fluid funding environment. I know that's not always the case for everybody. But as I said before, it really helped to have a tangible product that excited people. So we are both very happy to have questions, if you don't get the chance to talk today, especially if you want to talk to someone on the user side. Craig's very happy to hear from you. He's actually on holiday right now. So it may be a while before he replies back, but please copy me as well, and I will pester him to make sure he does reply if you want to hear his perspective on it. Thank you very much.